When we look at the essential steps of BLS, we call it as the chain of survival. Now, this picture, if you see interlinked chain like the Olympic rings, and each one is related to the other. You can't skip one chain and expect an optimal result. The idea of this chain of survival is to emphasize that these are simple steps which have to be done sequentially so that the chance of successfully resuscitating the patient is possible or feasible. So it is pragmatic to follow these steps. If you look at the slide, you see the first one is a telephone receiver. So indicating calling for help either locally within your environment or surrounding or calling for an ambulance. After you call for help, as you wait for the response from the emergency medical team, you initiate CPR, that is the compression and rescue breaths. As you are doing rescue breaths, if the help which you had called for is approaching you, you can share the responsibility of CPR with them. If you have access to an AED machine, automated external defibrillator, now is the time to start it and start initiating the shock process. This is part of BLS. You keep doing it till the patient shows signs of life or till you get access to the advanced cardiac support team or an ambulance which is going to shift the victim to the hospital or a coronary care unit. This is the same within a hospital, outside the hospital, or in a separate setup like a dental clinic, or even outside in a public space. The sequence of steps, what you do when you see a victim who is collapsing in front of you, is similar. Be it in a clinic, be it in a mall, be it in a house, or be it on the road. The first and foremost is safety of approach, safety for yourself and safety for the guy or the victim who has fallen or the lady who has fallen. So ensure there is safety for you to initiate the entire process. Once you approach the victim, be it a male or female, you check for response. You see if they are responding, you try and find out if there is a reason for them collapsing. If they respond, you can act on the response to do subsequently. You might need to call for help, or you might call an ambulance, or you might need to transfer them to a hospital. If they don't respond at all and if they remain unconscious, then we need to check for breathing. Is the victim breathing or not? And this process is done for 10 seconds. If there is breathing, then we put them in a recovery position. Still, we need to initiate the emergency system because we don't know why they are unconscious and how long are they going to remain unconscious. Is the breathing going to continue and improve, or is it going to suffer? So as we are waiting, at least we know that there is no loss of life as of now yet, and we still have a chance with them. But if there is no breathing, then it is a problem and we need to initiate the CPR. So as soon as you identify there is no breathing, we need to activate the ambulance services or emergency medical services. So if you're out of a hospital setting, we call 108. If you're within a hospital setting which has access to emergency medical response teams or the advanced cardiac life support teams, then you can activate the code blue in a hospital. This is universal in all hospitals. In our country, the ambulance services is 108. As the ambulance is on the way or as the emergency medical teams are on the way, we check for pulse. We, in the carotid, don't spend more than 10 seconds for it, and then immediately move on to CPR per se, compression and rescue breaths. Remember, now the sequence has changed to CAB, circulation first, so start focusing on compression straight away, addressing the circulatory issues. So 30 compressions at the speed of 100 to 120 per minute. After 30, stop and give 2 rescue breaths. Then go back to 30 compressions. So this is the basic cycle of BLS. Let's go through them step by step. If you look at safety of approach, this picture though is dramatic, it is imperative to make sure that when you reach a scene wherein a victim has collapsed, it is safe for everyone, safe for the victim and safe for us and safe for further help which is going to arrive. Like in a carriage which is collapsed, there is no point in doing CPR for somebody inside the carriage. It is mandatory to shift them outside, put them on a stable place and then do the CPR. If there is an electric gadget there, ensure that it is switched off and it is safe. There is a victim on the road, it is imperative to move them to the side of the road so that it's safe for us, safe for the victim, and possible for the help to arrive and initiate the entire process. Once you have ensured safety, then look for response. Let us take the scenario of a dental clinic which were there. Check for response. We don't do anything drastic, hit them or sprinkle water, which is as it is shown in a movie or in a funny way. The most important thing or the safest thing to check for response is to shake the shoulders and shout close to the victim. So as you see a scene where there is a patient being attended to in clinic and he collapses.
Sir, what happened? Sir.
So as we see, it is imperative to shake the shoulder and shout rather than hitting him on the cheeks or elsewhere. That is simple, safe, not a problem. The same can be done for a trauma patient as well, because shoulder shaking or tapping on the shoulder is not going to make any further damage to them. Once you shake the shoulders, you might elicit a response. You can ask or shout to them, is it okay? If he or she responds, then it's fine. Find out what is wrong and initiate the sequence. If they don't respond, then we need to look for breathing. For breathing, as anyone breathes, the chest moves up and down. So we look at the chest to see if the chest is moving. We can also go close to the victim's nose and mouth to hear the breathing. So our eyesight are towards the chest of the victim to see if it's moving up and down. How long do we do it? We do it for a period of 10 seconds, not more than 10 seconds. Don't underdo it also. Remember, a patient who is collapsed might have low respiratory rate. So it is imperative to check at least for 10 seconds. Now our normal breathing is 12 to 16 per minute. So that takes it to 3 to 5 seconds for breath cycle. So even if you're relaxing, you might do only 2 breaths in 10 seconds. So remember, there's a victim who has collapsed, so wait for the 10 seconds entirely before you try to make a decision.
Check for breathing. Breathing, take 10 seconds to check for breathing. Eyes towards the chest. Visit this. You can get your head to listen to the breathing, but more importantly, eyes to the chest. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So
breathing is there. Okay. See.
We could see the chest move up and down. For some it is abdominothoracic, for some the chest moves. So you can see the movement, rhythmic movement of breathing up and down and waiting for 10 seconds. One way of ensuring you know that 10 seconds is there is count out loud to yourself or loud. So the advantage is you know that you are waiting for the 10 seconds full. Remember, when you are panicking, 10 seconds is a long time. We might make a decision within 2 seconds, within 5 seconds and make a bad judgment call. So if there is breathing, then we know that there is still life and then there is still time to initiate treatment. If there is no breathing, then it is a disaster. So then before we check pulse, we try and initiate the next, try and activate, which is within the hospital setting, which is got access to advanced cardiac life support team, we will initiate code blue. If it's in a clinic setting, which is standalone or in a public place, we need to call for an ambulance. As we are checking for breathing, there are a couple of things which we need to be there. Normal breathing is there. Scan for chest movements. There are certain instances where there is jaw breathing when you will find the victim as if he is gasping and taking in air. That is an imminent sign of cardiac arrest, or that is a sign that the arrest has actually taken place.
Check for breathing at the chest, eyes straight to the victim's chest. See if the chest goes up and down. Your ears close to the victim and your cheek close to his mouth. Check for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There is no breathing. Call for.
So in this instance, we see that the chest is not moving at all compared to the previous slide. When there is no chest movement, then we initiate the emergency medical response system. So within the hospital setting, we have something called code blue. Out of the hospital setting, it's 108 ambulance service. There is an interesting snippet there. Why 108? We know in our country 100, 101 has meaning with police and fire, whereas the other numbers are free straight, they jump to 108. If you look at 108, it's a number which has religious connotation as well. Almost all religions, the number of prayers or rosary beads are 108. People try and pray or recite something 108 times. So 108 is a number which is close to people's heart. And remember, this is an emergency, and we tend to take comfort in whatever gives us a source of strength, be it prayer in any form. So that is why the makers of the Unified Ambulance System made 108 as the uniform call number, which is great, and it is easier for people to remember as well.
Sir, what happened, sir? Is anybody there? Please come. Emergency. Sir, flatten the chair. Let me look at his chest.
So you could see that there was identification of a problem, a treatment was being done, and that patient collapsed. So there was shake and shout. The victim didn't respond because immediately you know that somebody is there. You are calling someone to help you. If there is additional help, it is easier. So as you know that patient in a reclined chair is difficult, you can start looking at addressing the victim and the patient, whereas the additional help will help you with all the other paraphernalia. So as the chair is being lowered, you can see that the chest breathing is being assessed. The eyes of the operator is looking straight at the chest of the victim.
He's not breathing. 10 seconds, no breathing. Call an ambulance urgently, please.
So in a clinic setting, we won't have access to code blue, so it has to be an ambulance. So the advantage of having call for an help is now you know is help you make it flat as you're concentrating on the chest movements. Otherwise, you would be making him flat. You would flat, chair flat. You would be trying to position him, and then you have to run around for an ambulance. So that is why we say the sequential rings. So here, as the operator takes command of the situation and calls for an ambulance, and then you know that things are set in motion. There is additional. So as he has gone to call the ambulance, as the help who arrived has gone to call the ambulance, then next is being a healthcare provider. If you are comfortable, if you are confident, we can go in and check the pulse of the victim. So how we check the pulse is, look at the midline trachea, slide your hand thrice in between the sternomastoid, 3 fingers, and press on them. Adam's apple, you know the prominent part of the chest, neck, which moves when you swallow. So when he's lying down, feel that and slide 3 fingers onto the side and lock it underneath the muscle there. That is the sternomastoid muscle, and compress. You will feel the pulsations there. Just check if there is any pulsations felt.
Have you called the ambulance? Make sure, give the correct address for the ambulance. Let us start CPR. Let's remove the.
So for 10 seconds, again, not more than 10 seconds, as the ambulance is being checked, the operator decides to initiate the next thing in motion. So there is no breathing, no response, no breathing, and no pulse. An ambulance has been called for, and as we are waiting, then we need to start CPR. Remember, we need to compress the chest so that the blood in the heart is squeezed down and the other organs, perfusion is maintained. Even an effective CPR by hand, the BP is got only to 60-40 or 70-50, which is hypo in most of the cases.
Close. No breathing, no response. Let's start CPR, please.
So if there is a possibility to remove the patient's clothing, well and good. Here there is a pullover through the neck. It will be difficult to pull them over through the neck. If it is possible in the chair, safe in the chair, it can be done on the chair. Otherwise, the patient has to be shifted on the floor. But removing the pullover, meaning rolling them to one side, you are wasting unnecessary time. So depending on the cloth, you can continue. Remove the cloth or try and see. You can do it over the cloth. But remember, as long as doing it over the cloth is not causing more damage to the victim, and two, as long as you are sure about where the midline and the sides are. where you need to compress. You can identify those sites even with the clothes on, then it's not.
So the ambulance is on the way.
So we saw this in the hospital. For some hospitals, the numbers might be different. In certain hospitals, 1,000 for ease of remembrance. That is. So in case of a hospital, we will say which ward, which area. Whereas in an ambulance, I hope you remember in the previous slide, the operator said, please tell the correct address and a contact number as well. Because when the ambulance comes in our country, they need to know where to come, how to come. As soon as you call the ambulance, they know that it is an emergency. In panic, in an emergency situation, people tend to say, there's an emergency, please come here urgently, and hang up the phone. If that is done, it's going to be difficult for them to trace you again or call you again. But now with the caller number identification, they will call us again. But instead of doing that, it is easier if you could tell them the address and your contact number as well, so they can contact you again easily. So check for pulse, we will see that
3 fingers onto the side, into the valley, and feel for the pulsations. 10 seconds. Pulsations felt, breath felt, patient unconscious, evaluate the cause.
So far we were discussing no response, no breathing, no pulse. We can initiate CPR. If there is no response, you can see breathing, you can feel the pulse, you still might need an ambulance or evaluate the cause, or you can shift him to a hospital setting yourself. But that will need additional medical help also. But only thing is, if there is breathing and if there is pulse, you don't need to initiate CPR. So the pulse which you are seeing in the neck, as we discussed, along the side of the Adam's apple is a carotid pulse. If you are not sure how to check it, then ignore it. As healthcare providers, it is better to get trained to it. But if you don't know how to do it, if you are not sure, then no problem. There is more harm in assuming there is a pulse and thinking he is alive when a patient is actually not alive. Whereas if there is pulse and you still initiate CPR, you will do lesser damage relatively. So don't waste more than 10 seconds. One of the reasons why it is advised if you're not sure is, we tend to have people, when they are panicking, they feel their own bounding pulsation in the fingertip as the victim's pulsation and make a mistaken assumption that there is pulsation and treat the patient as alive, when in effect there might not be any pulsation.
Let's put him down. Get some more help. Yara Magna. Come. Let's hold him. Put him on a flat chair. Be careful, be careful.
So as you say, when the actual process of CPR is going to be done, it is going to be risky doing him on a chair where he might roll down and fall down. It's going to cause more damage. So it is better to put the victim on a stable platform. Only then when you compress the thoracic cage, chest, the thoracic cage gets compressed between the floor and the fingers of the rescuer. Then it can squeeze the heart. If it's on a chair, if he tips over and falls, he's going to cause more damage, you're going to waste time.
Let's put him down. Get some more help. Yara Magna. Come. Let's hold him. Put him on a flat chair. Be careful, be careful. Is the ambulance on the way? Yes, sir, I called. Let's begin CPR.
Continuously checking and communicating with our other assistants is imperative. They can check if the ambulance on the way, is the communication done. If they have missed something also, it is easier to identify and cover.
Let's put him down. Put him down.
So as we begin CPR, you can see that the operator knelt by the side of the patient, which is important. Proper positioning of the operator is mandatory if you want to do effective CPR. So you can see the operator kneels by the side of the victim and positions himself just above the chest of the victim. Don't squat, don't put your don't stand, or it is all uncomfortable positions. You will hurt your back, and moreover, the quality of CPR is going to be compromised. So when you are going to start compressions, we say push hard, push fast. So the best way to push hard, push fast is put them on the floor, kneel by their side, position yourself on top of the victim's chest, and interlock your hands, and then start compressing. If you see the shoulder, elbow, and wrist are in a common straight line. The hands can be interlocked, that's fine. The heel of the hand, what we call the heel of the hand, is placed in the center of the chest. The center of the chest is the sternum bone, breastbone, it is placed there. Don't keep it on the side of the chest, either side. No, that is not good. It will fracture the ribs and it won't be effective CPR. The center of the chest, the breastbone, sternum is quite strong. All the ribs are attached to it. If you press the sternum, automatically the entire rib cage will collapse. And you can give good compression with the with the hands on the rib cage. So you can identify in the midline, placing the heel of the hand on the sternum. The fingers can be on either side, it doesn't matter.
On the shoulder, elbow, and the wrist.
Whichever is on that side, either on the left or right of the patient, it doesn't matter. This is just doing the entire process. So removing clothing.
Sternum, midpoint of the chest, hands one above the other. Start. 2, 3, 4, 5, 6, 7.
The top is that a demonstration on a mannequin where it is happening. When you compress, you could see how much the compression goes and the ventilation, and here you can see what is the speed of compression. So here speed of compression, here is the depth, and then how much it will do. This ventilation is when we are breathing.
Let's remove the fluid. Sternum, midpoint of the chest, hands one above the other. Start. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. Let's give breaths. So
when we see that the compression is given, the speed of compression is such that you do 100 to 120 per minute. We are not going to do 120 at a time. We are just going to give 30, stop, and then concentrate on breathing. So for rescue breaths, it's going to be mouth to mouth breathing. When you are giving mouth to mouth breathing, it is going to be head till chin lift. We will look at it again.
One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 17, 18, 19, 20, 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 14, 15, 16, 17, 20, 1, 2, 3, 4, 5, 6, 7, 30. 1, 2, 3, 4.
So if you see, the compression continues. Compression versus rescue breaths. Compression versus rescue breaths. 30 is to 2. For an adult, it doesn't matter how many people are there, it is 30 is to 2. For a kid under 8, if there are 2 trained rescuers, it is 15 compressions is to 2 rescue breaths. There is only one person or you are the only guy, then it is again 30 is to 2. So the quality of compression is imperative. If the quality of compression is poor, then heart is going to be squeezed less, the amount of blood going out is less. So the quality of resuscitation is going to be less, and you don't have enough time, and it will be futile. So center of the chest, don't put the hand on the side of the chest, it will cross the ribs, crack the ribs, but not effective CPR. So center of the ribs, depth of 5 to 6 centimeters, rate of compression is at the rate of 100 to 120 per minute. But after 30 compressions number is, you give 2 rescue breaths. So you continue, 30 is to 2. Well, we saw in the previous slide how the correct position, shoulder, elbow, wrist in the same straight line, fingers interlocked on each other, heel of the hand on the sternum, in the center, it's fine. The fingers can be either side, it doesn't matter, it's the pressure is on from the heel. But there is a tendency in emergency to do things negatively or in a wrong format where the elbows are bent and fingers are interlocking in other directions. The problem with that is the effectiveness of compression is not great. One and two, you tend to get tired soon. Remember, we need to keep giving it till the patient recovers. So don't do what is shown in the picture. That is no. That's why you get a cross sign. That is a wrong way of doing. You see the strain on the operator. They're not able to get, as if the elbows are bent, the pressure comes, the strain comes from the wrist. It is not good. Don't hold the chest on either side and try and compress. No, the ribs will crack. So, if possible, we'll show that. So you are not able to get the compression depth and the speed as much as we used to do before.
Elbow மடங்கி இருக்கிற மாதிரி எடுங்க.
So all these are not good. Right from the top end of the patient, from the bottom end of the patient, the hands against each other. Now the best one is by the side of the victim and shoulder, elbow, wrist in the same straight line.
That's Ziffy's sternum, midpoint of the chest. Place the heel of the hand on the midpoint of the chest. Interlock fingers or keep them straight, doesn't matter, whichever side is okay. And shoulder, elbow, wrist in a straight line, start compression.
So one tends to get tired if we keep doing it. So we tend to change operators every 2 minutes or 5 cycles of CPR. Within a 2-minute period, yes, if the quality or the style of CPR is accurate and good, then we should aim to finish at least 5 cycles of 30:2, compression plus respiration. So avoid interruptions. Keep it continuous till help arrives. If it's within a hospital, if we get an AED machine, then it is great. So again, don't stand and do. It is not feasible.
Ready, sir.
So don't do with alternate legs. Best is to kneel on the side. Don't lean forward. Don't lean backward. It is not good for your back. It is a problem. When you look at rescue breaths, this is mouth-to-mouth breathing. So the idea is to effectively ventilate the patient. Our expired air, the rescuer's expired air is going into the victim's mouth. So he inspired. So our expired air has enough oxygen to go in. Remember, there might be a lot of vomiting in the victim's mouth. It is imperative to suction them out before you blow the air in. There was a problem of doubts with communicable diseases transmitting from the victim to the rescuer. As of now, we can safely say there is no known report of communicable disease like HIV or hepatitis B spreading from the victim to a rescuer. But still, some people might be reluctant. The best is to use a mask. That's why, as all healthcare facilities should have a mask, you can avoid this totally. You seat a mask on the victim's mouth and blow into the mask. Some people, that's why, tried a mouth-to-nose respiration. Some people put a kerchief, but no, mouth-to-mouth is the most effective one. And you give 2 rescue breaths within 10 seconds and move on to compression. So when you're doing, we need to open up the airway. The best way to open up the airway is to tilt the forehead and lift the chin.
Head tilt, chin lift, pinch the nose and breathe.
So we saw effectively how the head was tilted on the forehead, not on the scalp, on the forehead. As you tilt the head and lift the nose, the tongue is dragged out of the posterior pharyngeal airway and there is space. So now if you blow into the victim's mouth, the air can go into the lungs and expand the lungs. So when you're blowing, the hand which is holding the forehead is actually pinching the nose.
Head tilt, chin lift, pinch the nose and breathe.
I was reiterating the right way of one. Let's look at another way which is not so good. The challenge here is, in panic, people tend to go and hold the neck. We are actually compressing the neck and make it difficult, and pushing on the eyes of the victim is also a problem.
Head tilt, chin lift, pinch the nose.
And without pinching the nose, and mouth to mouth is creating an effective seal is important. So the second bottom one is how not to do or what not to do. Blowing from a distance away, afraid, is not effective at all. So the top picture is what we should aim to do. So we have seen the compressions, we have seen the rescue breaths, 30:2, and we give. So as we blow into the victim's mouth, we don't need to take excessive breaths. No, our normal expiration is fine. Blow when you can see the chest rising and fall down. Just give a second, do the second breath. Once the chest falls down, immediately start taking on compression. If there are two rescuers, one can give the breath, one can give the compression. As 30 compressions are over, the one at the head end starts giving the rescue breaths. As he is finishing the second rescue breath, the one near the chest can start compression. If you have access to a mask, you can place the mask and blow into the mask. If you have access to an oxygen circuit with oxygen, you can give continuous supply of mask. Don't interrupt for rescue breaths. You can start continuously doing compressions also at the rate of 100 to 120 per minute. But we tend to tire out, so it is better to swap the operators every 2 minutes. If you have a bag and mask, rescue breaths with bag and mask is better.
Flood. If you have a mask, easy.
So using the mask is easy technique. The mask has to seat comfortably, tightly around the mouth and the nose of the victim. So and you use your fingers to get a seal. One is to pull the chin against, one is on the forehead. So in the form of E and a C.
Flood. If you have a mask, easy.
An ambu bag gives better atmospheric air than us. Or you can blow directly into the mask. If you don't have ambu bag, keep the mask and blow into the mask. So 30:2, we keep continuing the cycle till we, nowadays, in the last 10 years or a little bit early, longer also, the AHA has incorporated AED devices, the external automated external defibrillators, into the BLS part. So how does it work? We will know. We will just see in a bit, but this is just reiterating the same things which we saw. First is safety of approach, check for response. If there is no response, call the help, check breathing. If there is no breathing, activate the emergency medical system. It's code blue in a hospital, it's 108 ambulance outside. As the help is coming, check for pulse if you are comfortable. If not, ignore it. Then initiate CPR ASAP till that help arrives and takes over. Now, look at a scene. This is basically BLS was what about? Over the last 10 to 15 years, what has been identified as certain types of heart attacks respond well to shocks. The other types don't respond well to shock. So how do we know which types? That we know based on our ECG patterns. These types like ventricular tachycardia, ventricular fibrillation will respond to shocks, what is called defibrillation. So if you defibrillate, shock them, there is a good chance they will return to sinus rhythm. By sinus rhythm, what we mean is normal electrical activity of the heart. And then you can take them and evaluate the condition. So in those conditions, if you leave it late till defibrillation, after a while it will become irreversible and it will become flatline, and then later giving shock at a much later time doesn't help at all. So identification requires ability to identify an ECG. However, with the technology, we have been able to incorporate the machine which will identify the ECG and advise to the operator whether shock is advised or not. However, remember, the machine does not give shock on its own. The machine has to be operated by the operator. It will give you instructions as to what to do, how to do, and even when it's saying to advise shock, it will say shock advised, press the button. It is not going to shock by itself. Until otherwise we press the button, shock won't be given. So if we have access to an AED, as we discussed earlier, even 5-star hotels or public places might have AED. So if there is access to AED and the person brings the AED, you come and attach the AED. AED is nothing but a small box which is there. And once you open the box, switch it on, it will also start giving out voice prompts as to what to do. So it will give you clear directions as to what to do, and we just have to follow them. So the AED will open up. Sometimes there's a toggle button, the button with the circle and a line in the middle, what we call toggle button, on-off button, or some will switch on by themselves. So as soon as you open them and switch it on, the automatic voice prompts will start coming. So it will say remove the patient's clothing, and then it will say attach the ECG pads to the victim's chest. So we need to remove the shirt because we need to attach the ECG pads to them. Conventional ECG, we might have 6 leads or 12 leads, whereas this has got only 2 leads, and there is a pictorial representation as to where to attach them. One is at the left side near the apex of the heart, the other one is diagonally opposite near the shoulder on the right side. There might be a pictorial guidance as to where to attach them on the ECG leads themselves. There are only 2 leads in an AED device. As soon as you attach them, you don't stop. CPR is being continued by somebody, the compression. As soon as you attach the leads, the machine will prompt you saying, assessing the heart rhythm. So at that time, it will say stop compression, we don't disturb the patient, we move away. Because the machine is assessing if there is any electrical activity of the heart of the victim. When we are compressing, it can get misconstrued and it might not get an accurate reading. So as the machine is assessing the cardiac rhythm or assessing the heart status for ECG pattern, stop the CPR and don't be touching the patient. So analyzing rhythm, do not touch the victim. This will be a voice prompt as well. As soon as it analyzes the rhythm, it will say shock advised, or then we have to shock, or it might say shock not advised, continue CPR. So if it says shock indicated or shock advised, the machine won't shock by itself. It will say press the shock button, and the shock button might flash. So we just have to press it and the shock will be delivered to the victim. As we are delivering the shock, one most important thing is we need to warn anybody else close to the victim to move away. Moreover, we should not be touching the victim as well, because otherwise we are going to get the shock as well. So as the machine says shock indicated, press the flashing shock button as the picture shows. Say going to shock, all clear, I am clear, meaning I am of the victim. You clear, all clear, and then press. I'm going to press the shock button and you press. As soon as the shock button is pressed, we are not going to wait to see if the victim is coming back. We need to start CPR immediately after the shock button is pressed and shock delivered. So CPR is again 30 compressions is to 2 rescue breaths. For how long? 2 minutes. And after 2 minutes, you stop and see if the ECG will be assessed by the machine again. The machine will say rhythm normal or shock advised or shock not advised. If it says shock advised, we are going to repeat the process. If it says shock not advised, we will continue CPR and maybe need to give medication. The medication will be based on the ACLS guidelines, hopefully. But if there is no ACLS people around, we will just continue 30 compressions is to 2 rescue breaths for 2 minutes, get the ECG reading again, and then continue this, depending on what the machine is doing. So this is the cycle, just to simplify the log chart of this. An unresponsive victim who is not breathing or only gasping like that, activate the emergency medical system and start CPR. As soon as you start the CPR, see if somebody can get you an AED machine. Check if shock is indicated, advise shock. So when you're compressing, now the dictum is push hard, push fast. Good quality CPR is push hard, push fast, meaning as much as you compress the chest, then the heart is squeezed and blood flows all over. Remember, when the heart is stopped, the other organs are functioning. And if we manage to revive the heart, he won't have any other problem, as long as we keep them oxygenated till the heart becomes better. Let's look at a scenario where the victim has starting to breathe normally or is breathing normally from the beginning. Then we keep them, and also you can get a feeble pulse. We keep them in what is called a recovery position. Recovery position is nothing but the position which our patients are kept after an anesthesia. Recovery position basically means putting the patient onto one side, or what we olden days we used to call lateral decubitus position. And as an individual, when the victim is on the floor, how are you going to put them in recovery position? We also have to ensure that they don't roll back to supine position like this. The problem with the supine position is there is tongue fall back, the secretions in the mouth might be aspirated in an unconscious patient. If you put them on a lateral position, recovery position, the tongue fall back is minimized, the saliva or whatever secretion is in the mouth will drool out and not choke the victim.
Reading, sir?
ಇದು like full head
Full body. When the patient is breathing but no response, still call for medical help, and as you're waiting, turn the patient to recovery position.
Okay, sir.
So this, what we are doing to recovery position is, we are, you can see. So you see the legs are locked there, so he doesn't roll back in. One hand to support the chin, other hand away, and it is drooling. So you can leave him in like that. See the face looking down so that everything flows out, nothing chokes him. And the tongue also will have a downward thrust, opening up the airway at the back and him able to breathe. So just to go by step, step 1 is first pulling the hand away, 90 degree away. The second one is getting the opposite hand on to keeping it on their chin and flexing it. Next is the opposite leg, you are flexing it and rolling the patient towards you and putting him on the lateral position. That way he is self-retaining. So if you look at children, the CPR as we saw, children is slightly variant. Remember, the chest is not well developed, the size of the kids are small, and children are not miniature adults. The physiology is slightly different. So, and the way the problem comes is mostly respiratory in issue and not cardiac. So, but still you do what is comfortable for you, what you are familiar with. If you're not comfortable with PALS, pediatric life support, you don't have to worry, you just follow the adult pattern. Only thing is, if possible, if you can, if there are 2 people available, you are going to use 15:2 ratio, 15 compression is to 2 rescue breaths rather than 30:2. So adult technique, but however, if you're confused, don't worry, you just use the adult technique. So in a kid, we can't look at 5 centimeters because the entire chest wall thickness is less. You're not looking at 5 to 6 centimeters depth of compression. You look at, say, 1/3 of the depth of the chest is the compression going to be done. So if it's a newborn within 1 year, you just need 2 fingers in the middle of the chest to compress, and then you can see that mouth to mouth breathing is also tricky. You don't have space to tilt the head, you might just lift the chin and give them. If it's either 2 fingers as in this picture, or you might need to embrace the kid and use your thumb to compress the clavicle, compress the chest wall for compressions, depending on the size of the kid. If you are looking at AED, if the kid is greater than 8 years old, we can use adult AED pads. If they are lesser than 8 years old, better to use a pediatric pad because the pad is bigger in size and a smaller size pad will help. If for a kid lesser than 1 year old, look at instructions, and these are special pads. You don't want shocking the child too much and causing more problem. So anybody above 8 years, if you don't have access to appropriate size, you can use an adult AED device as well. So there are 2 sets of BLS here. Only difference is AED incorporated in it or AED not incorporated in it. So we are looking at approach safety is the same in both. Checking for responses again there, checking for breathing, activating code blue or emergency medical system, and checking pulse is the same. So as you start CPR, you continue. If you don't have the machine, you continue CPR till ambulance arrives, till help arrives, or patient shows signs of life, meaning he's breathing and he's pushing you away. Whereas if you have access to AED, so you start compression, when the AED comes, you are not disturbing the patient when it's analyzing rhythm. Other times you are going to do CPR, compression is to rescue breaths. Once the AED analyzes the rhythms, it will tell you, prompt you as to what to do. If it says continue CPR, continue CPR. If it says shock advice, it will flash the button, press the flashing button. And when you are about to press the shock button, get everybody to move away from the patient. Say clear, pressing the shock button. When shock is delivered, don't wait, continue CPR immediately for 2 minutes and then reassess the rhythm. It will say analyzing rhythm again and then follow voice prompts. So it's the same prompt again. To summarize, an unresponsive, no breathing, no normal breathing, agonal breathing, gasping patient. As you approach him to give basic life support, we are going to activate the emergency system. If there is, when you are looking for breathing and pulse, don't spend more than 10 minutes for each, 10 seconds, for each. And then when there is no response, hopefully with help on the way, start CPR. If you have access to AED, use AED and check the rhythm and then continue. There was an issue in common practice in the common road. In a hospital setting, it's fine. In a clinic setting or outside, will there be any issues with the law? Because when somebody collapses in a clinic, it is traumatic. And then you're compressing and somebody thinks that with the patient, gasping patient, and then after your compression, if the gasping stops, when he stops breathing, they think that you have killed the patient, or is there a problem? Though there is no law saying it will directly protect you from CPR, because it is very difficult to differentiate for them, but rest assured that nobody gets penalized for CPR. The judges are quite clear that when somebody collapses, cardiac arrest, nobody knows, and they will support you for CPR, whatever the patient's attenders say. However, if you have not initiated CPR, and if you are just going to wait for an ambulance to come without even doing CPR, then you will be held accountable and you may be penalized for that, because in that case, if you are undertaking a procedure, if he is going to crash, legally they think it is mandatory you know the emergency basic life support measures, first aid measures, because it's now moving on to even the public space and we want even public to do it. So then there is no reason why as a healthcare provider we shouldn't do it. It is mandatory, we know, and we initiate the correct process. Is there a risk for infection? We saw that as of now no reports have come in literature about communicable diseases going this way and that way. The commonest problem with people not doing CPR is we don't know how to do, and that is the aim of these lectures. But remember, lecture alone is not sufficient. Let us work on a mannequin. Maybe we will look at this project or later how you can do it on a mannequin. We will have an assessment test like you have at the end of this exercise to see how you do it. And then your uncertainty if it's wrong. The best way is to keep practicing. And remember, every 2 years it is best to get it recertified. Let us volunteer and be there. This is just to bring to your attention the importance of immediate CPR. If you are football fans, and I think this is 3-4 times it's happened, of late in the West it's happened. If you're a football fan in the recent Euro 2020, it's happening in 2021, right? Due to COVID pandemic. So due to Euro, one of the players from Denmark, Christian Eriksen, just collapsed on the ground as he was going to get a throw-in from outside. His colleague, Simon Kjær, I think, was there. He immediately put him lateral, swept his tongue. He felt Eriksen was swallowing his tongue, so he swept his tongue, cleared out his airway, and then got the medical team and started doing CPR. In fact, Simon Kjær has been awarded a special award for his timely response in identifying the tongue fall back for Christian Eriksen. And that helped the medical team initiate CPR and save him also. In fact, Eriksen has come back to playing football again. So high quality CPR can save lives, and high quality basic life support incorporating AED with good compression and AED, 60% chance if the CPR is initiated within the first minute or so. Witnessed arrest, that is what we say. So we are looking at another scenario wherein if we can do If there is a choking scene, how we can go about looking at a victim who's suddenly choking. You see the universal sign of choking with them holding their neck. The hand going
What
to the
happened?
neck is a sign of choking.
Lean forward, lean forward, lean forward, make payment. Cough, cough. Okay, let's try him lift. Start. Relax, relax. You're okay? Take a deep breath. Okay. Very good. You're able to breathe, okay? Okay.
So, when somebody is choking, the sign of gasp is hands to the neck, and then they're struggling to breathe. The best thing is make them lean forward, make them cough. Remember, for cough, they have to take in air, and the airway is blocked. The best thing is to make them lean forward and tap between the shoulder blades in the back, like you saw in the video. Keep tapping 5 thrusts, and then see if they can get it out or cough. If they're still not done, then Heimlich is the solution. If they're in a chair, making them stand up is difficult. You can go behind them and then do, is the commonest thing, but in a chair you can directly do it. In a chair, going behind and doing it is difficult. And remember, the thrust has to be with the elbows right to the below the xiphisternum. Don't try and pull the elbows up, chest cage up. It won't help. If you're not able to retrieve the foreign body and the respiration stops, then we are going to initiate CPR, the BLS sequence, which we saw just like that before. Thank you very much. I hope it was quite lucid and clear cut. Please attend to the tests at the end, and then we look forward to interacting with you again later. Thank you.